Good day, everyone. This presentation was prepared for the World Regional Anesthesia Day, and I want to thank the organizers who made it possible in our setup. So I'm Dr. Ndlovu. I'll be talking to you about the complications of peripheral nerve blocks. So this is the outline of my presentation. I'll give you a brief introduction. I will explore the question of what is a complication. We'll look at the complications associated with peripheral nerve blocks and the evidence associated with that. Then I'll touch on mitigating measures and finally the conclusion. So over the years, several articles on the benefits of peripheral nerve blocks have mushroomed. And one interesting article is the one in front of you by Mensudis et al., published in the BJA in 2019. The authors of this article stated that the use of peripheral nerve blocks reduced common post-operative complications. And it is this article and many others that have led to the advent of many peripheral nerve blocks. So this huge amount of peripheral nerve blocks allows us to tailor our pain management. However, it also opens the door to new complications that we need to be aware of and need to mitigate. So what is a complication? A complication is an unanticipated, unfavorable medical outcome that arises following and is a result of a procedure, treatment, or illness. When it comes to peripheral nerve blocks, the main complications are divided into local or systemic. Local complications include nerve injuries, hematoma, infection, inflammation, ischemia, nerve pulses, to name a few. Systemic complications involve anaphylaxis, seizures, myocardial infarction, and local anesthetic toxicity. So what are the risk factors to peripheral nerve block injuries? The risk factors can be divided into patient, anesthetic, and surgical. Patient factors refer to the baseline characteristics of the patient that put them at an increased risk of nerve injuries. For example, an elderly patient or a patient with diabetes. Anesthetic factors speak to the actual procedure as to how the nerve block is conducted and the level of expertise of the person performing that particular block. Surgical risk factors relate to the use of tourniquets and patient positioning in the operating room. The mechanisms of nerve injury can also be divided into three: mechanical, chemical, and vascular. Mechanical relates to actual trauma to the nerve. Chemical speaks to the use of agents, even local anesthetics can cause nerve injuries. Vascular mechanism it involves processes that lead to ischemia that then compromise the blood supply to the nerve, leading to nerve injuries. Paying a little bit of attention to the actual anatomy of the nerve. So a nerve consists of what we call fascicles. So the fascicles are bound by the perineurium. The perineurium is a protective layer around that bundle of fascicles. And what happens is that the perineurium also serves as a barrier to local anesthetics. The perineurium consists of collagen and other tissues, and it is quite robust. It's also important to note that the nerve tissue has an intrinsic and extrinsic blood supply. So even in the most experienced hands, complications can occur. And in an article published by Seddon in 1954 in the British Medical Journal, he outlined that there were 3 types of nerve injuries, namely neuropraxia, exonotemesis, and neurotemesis. Neuropraxia occurs when nerve fibers are compressed or stretched. This type of mechanism of injury leads to damage of the myelin sheath. However, it does not impede nerve conduction, though nerve conduction can be delayed. Recovery is quite good, so the prognosis in general is good. Exonotemesis, on the other hand, speaks to injury of the axon fibers. Conduction is impeded, recovery is unpredictable and can be slow. Neurotemesis refers to complete transection of the nerve fiber, and often surgery is required to restore the integrity of the nerve. So what is the evidence behind peripheral nerve block associated injuries? In an article published in 2021 by Kevin Fan and 2 other authors, they state that the incidence of complications in the adult population following a peripheral nerve block is less than 1%. This is a very interesting article that I would recommend you should read because the authors explore the risk factors associated with nerve injuries and how to mitigate them. What about in the pediatric population? So in an article published by Catalani and Jones, they mentioned that they looked at data from 2 big databases, one in France and the other in North America. What they established from this information or this group of data is that the incidence of peripheral nerve block injuries in the pediatric population is quite low, in fact 0.12% according to their data. However, they issued a cautionary statement that in patients less than 6 months of age, the risk of complications is 4 times as high. They also stated in this article that children are at a high risk of local anesthetic toxicity because their livers are immature and hence they are not able to metabolize local anesthetics effectively. They also have a low amount of alpha-1 glycoprotein, which means that there's increased free fraction of local anesthetic that is circulating in their blood following the administration of local anesthetics. And this puts them at a high risk of developing local anesthetic toxicity. So in the pediatric population, it's very important to make sure you calculate local anesthetic doses very well. Another important thing to note is that in the pediatric population, it is difficult to pick up complications associated with peripheral nerve blocks, and also to assess for the efficacy of a block also makes it quite difficult as well. So what about in our setup, African setting? So if you were to do a literature search, you'll find that there are very few articles which talk to the incidence of peripheral nerve block complications, if there are any. So there definitely is a gap in literature. So what about our setup? So after many blocks were conducted, and to be precise, we had about 400 blocks which were conducted in patients with orthopedic conditions. What we noted is that 2/3 of our patients were male and 1/3 were female. What we have noted in our setup is most of the patients that present to us with orthopedic conditions they are mainly trauma-related than other pathological, than other disease processes. And in the upper limb, we found that amongst our patients with upper limb injuries, most of them had forearm injuries. And in the lower limb patients, most of them had tib fib fractures. Then in terms of the blocks, supraclavicular was the one that was most popular, followed by the interscalene block. And amongst the lower limb patients, the blocks tend to be more diverse and were tailored to the particular joint or pathology the patient presented with. What was of note is about 91% of the patients were satisfied with the blocks. 87 of the patients voiced that they would recommend that block they had received if somebody they knew needed a similar procedure. Looking close at complications, we did notice a gap in our pain management, especially on the night post-surgery. And hence, we started including steroids in our local anesthetic mixture and also using adrenaline to prolong the analgesic effect of the block. Of course, there are different views in different centers, but we found that adding steroids, namely dexamethasone, and using local anesthetic with epinephrine or adrenaline did prolong the duration of the block and improve patient satisfaction. We also began to conscientize the nurses about the importance of administering non-steroidals if they are not contraindicated, and if the pain is not well controlled, no steroidals, to give opioids. But the aim was to reduce the opioid consumption during the hospital stay. And when it comes to complications like paresthesia and weakness, it can be quite difficult. And we noticed that as well when we were doing follow-ups. It's quite difficult at times to differentiate what is surgically related and what is the actual anesthesia contribution. And often there is overlap. And I must say that even if patients do experience some numbness post-surgery, it tends to resolve. And we found that in our patients, it tend to resolve, especially by the time of discharge. Patients would, if they have some sort of paresthesia, it tends to get much better. So in the process of performing all these blocks, one needs to balance the desire to achieve block success with patient safety. And in order to do this, it's important to have workshops that help doctors to practice how to perform these blocks correctly. And those who are trainees to get the adequate form of instruction so that they do not cause nerve injuries. And for those who are already au fait with the blocks, to sharpen their skill. And this is what one of our trainees was doing, was practicing hand-eye coordination and needling using a piece of meat. So what's the evidence behind this? So this article, and there are other articles, regional anesthesia and acute pain, they looked at ultrasound-guided regional anesthesia simulation training, systematic review. And they found that performing workshops that involved simulation training was very helpful, as it enabled trainees to gain confidence and hence improve block success and mitigate peripheral nerve block associated complications. How else can we reduce peripheral nerve block complications? Use of ultrasound, combining ultrasound with injection pressure monitoring, and also the use of nerve stimulators. No one modality will completely reduce complications. However, there is a sweet spot where all three intersect, where you can markedly reduce the incidence of peripheral nerve block associated complications. In addition, the use of checklists. In our setup, we use the stop before you block, which was adapted from the UK regional anesthesia guidelines. In the stop before we block protocol, we aim to identify the patient. We establish that consent has been obtained, both written and verbal consent, and that the patient is aware of the possible complications can occur with due to the administration of the block. We make sure that the surgical site has been marked, and we all agree as the team that the proper site has been marked and the correct block for that particular operation is being performed. Monitors, standard monitors, must also be attached before the block is administered, including an patent IV line, and the staff involved in the block should be aware where the emergency drugs are, including intralipid, should a local anesthetic toxicity should occur. And obviously it is rare, but if it does happen, it's important to know where the emergency drugs are. So in conclusion, regional anesthesia is it's a rapidly evolving field, and it presents many opportunities for up-and-coming doctors to practice their skills at performing peripheral nerve blocks. However, in the effort to optimize the patient's pain experience in the perioperative setting, we should be guided by the principle of primum non nocere, which is first do no harm. Therefore, patient safety should always take priority over block performance. Thank you for listening to me. These are my references, including the articles that I showed you in the talk. And if you have any questions, please, you can post a comment, or try and reply. Thank you.